So Ken, you're very active, you're fellowship trained, you've got a huge practice up there in Detroit. You've got all these tests, you've got 60 partners that are probably looking at you and saying, Ken, help us here. So how, from a group standpoint, operationally, how are you putting this in place? What are you allowing everybody? Are you the final say? How are you guys putting this in place?
I mean, I think one of the challenges, like you said, is we're just trying to continue to educate our partners as well as the patients on all these different tests. So we've put together a kind of an advanced prostate cancer group of about 12 of us that specialize in prostate cancer and have a passion for prostate cancer. And we try to disseminate and decipher all these things at those meetings and then disseminate those out to the rest of the group. Obviously, I think the big challenge is who to treat. And I think that's where there's a lot of opportunity. And we talk to our patients about really being able to tailor or personalize their care. Because I think a lot of times people think, hey, if I have this disease, I'm going to get this treatment. And now that paradigm really is changing. So we're able to help them through their fears and get through that to say, hey, look, for you, you may not need treatment, and this is why. So we're really using, the Polaris test as well as the Genomic Health Oncotype DX test to help kind of figure that out for those patients and tailor that treatment.
Are you doing any kind of reflex testing? So especially for maybe low risk, very low risk or low risk patients, is that still under the auspices of the treating physician, or as a group are you saying, boom, every low risk patient is going to get this to better determine who is maybe a more appropriate candidate for active surveillance? Same on the negative biopsies.
Right. So from the negative biopsy side, we're kind of reflexing the oncotype or the confirmed DX, because we think, again, that's one of the things when you talk to patients about fears, like Chris was saying, it's easy somewhat to talk to a patient about when they have cancer. When they don't, and yet that PSA is high, or there's some cells in the biopsy that you're suspicious of, that's really one of those things that we're trying to do. So that, for us, gets reflexed to confirm DX, and that really has helped us who to re-biopsy and all that. With regards to the genomic health versus the Polaris, we haven't really reflexed those yet. We're kind of leaving that on an individual basis. We've done trials for Polaris, and now we're actually doing a trial for the Oncotype DX and trying to just better understand who's going to succeed, give us the best information to treat those patients.
Chris, same?
Well, I think very similar. I think part of the problem is that with all these tests that are out there, it's hard for us to understand here on the panel, let alone our partners. So I think that the good thing about having sort of larger urology entities is that we're collectively allowing sort of the thought process and some standardization to happen. And what I envision happening is really a lot of this is going to be dependent on what the insurance will pay for. To my knowledge, any of the tests that I talked about, no one will pay for yet. So the patients either have to kind of sign paperwork, and that in of itself is anxiety producing. I think that of the tests, the ones that are, the one that I like is the sort of the GPS score. And the reason I like it is because it sort of tries to buttonhole it into the NCCN guidelines, which in my mind is going to be what insurance payers can understand. If you talk to some insurance payer about mitochondrial DNA or, cell cycle regulation, it's going to be very hard, but they understand the NCCN guidelines, and I think that that's going to be one of the ones that's going to be most easily and readily adopted in this whole process.
Neil, you've worked pretty closely. I mean, again, this whole thing about, reimbursement's a big issue. It's a challenge. We've seen other companies basically go by the by because they had great science, can't get this thing reimbursed. And so there was this aspect that we alluded to earlier, clinical utility.
Yeah, this is very important because we have a history of a lot of assays, biomarkers coming to market that, quite frankly, they didn't do the clinical validation. They didn't necessarily even do full-throated assay validation. So it's a stepwise process. Assay validation, clinical validation, and then the third part is clinical utility in a prospective study. What does that really mean? It means that if I bring you a test and it's going to cost X and it's going to give you a certain amount of information, does it really change what you do? Does it impact your active surveillance rate? Does it impact your interventional rates? And to the credit now of the Molecular Diagnostics Program, which is the acronym or MOLDEX, which is run by Dr. Elaine Jeter, it's forcing, really committing the biomarker industry to come in and say we have to do these prospective clinical utility studies to show that the physician and patient took the information and that it indeed changed behavior. And I think that's a really good thing for all of us, not only as clinicians, but as taxpayers. And that way it forces the entire biomarker diagnostic industry to do the studies that need to be done so that panels like ourselves and our colleagues listening can say, okay, I really see that if I order this test and it costs X dollars, it's going to really impact what I do. And so there's such a thing known as the LCD, the local coverage determination. And right now, they're just starting to get some early local coverage determination. LCD is the confirmed DX test. And there's a draft now in front of MolDX, and it's open for commentary right now on the Prolaris genomic assay. And that's really done on the basis of them having completed a prospective clinical utility trial. And I know Genomic Health is doing the same thing as we speak.
Brian, anything? I mean, you're out there in Eugene, and you're the only show in town in Eugene except for Nike, right?
And the Ducks, yeah.
And the Ducks.
I agree with everybody else's comments that we're all still trying to figure out which tests to do. We're still getting our feet wet with them, and I think growing our understanding of them. And it'll be interesting how it all sorts out, both monetarily and clinically, what we all feel is useful in helping our patients.
And I was just going to say, I think, since these tests have come out, we're starting to see a rise throughout all our partners of active surveillance going up within our practice, which I think really is the goal. We want to treat people who need to be treated. And I think that's why it's an exciting time, and hopefully that translates into, like Neil was talking about, cost savings to the healthcare industry by treating people who need to be treated and actually allowing those people to just be on active surveillance who actually don't need to be treated.
Yeah, I mean, I think, we are moving into a world of value-based medicine, and value-based medicine is basically defined as outcomes divided by cost. And just because you spend a little bit more money up front, if it provides value, if a person doesn't need a radical prostatectomy and all the issues that go along with that, you are providing value and you bend that proverbial cost curve. And so again, I think the way we look at this test, it's not about how much you spend, it's what you get for what you spend. So,
but it also feels like a little bit of a moving target with change of primary care doctors and how they screen for prostate cancer. I mean, the cohort of people that we see now is maybe a little bit different, and there's a lot of moving parts here. At the same time, we're trying to figure out which genomic tests are the right thing to do.
And I think it is incumbent on the urology world, whether we be in independent practices, part of an integrated system, part of an academic system, wherever, it is incumbent upon us to really take the lead on this. So, okay.